video is about the peripheral nerves, which can be divided into cervical, thoracic, lumbar, and also sacral. But the main aim for this video is to describe on the lumbar and also the sacral nerves, sacral plexus. So the lumbar starts with the T12 until L5, while the sacral starts from S1 until S4. So let's begin with the lumbar phase. So how to remember this? Basically, you have to try to imagine the innervations that it gives. And this is also one of the favorite questions in Mrcog. So let's begin with the first one, which is the T12 and also the L1. So T12, L1, we have here is the iliohypogastric. Iliohypogastric basically will give rise also to the ilioinguinal nerves. So iliohypogastric basically what it does is it innervates also the mons pubis. So iliohypogastric here, it's innervate the mons pubis. And then the ilioinguinal, the famous one whereby it goes inside in the inguinal canal together with the round ligament in female and also in with spermatic cord in male. So it does gives innervations to the labia. And the question that they usually ask is about which nerves basically runs together with the round and spermatic cord. So it gives some innervations to the labia. And after that, what we have in the lumbar plexus is the L2, L1 and L2, which is the genital femoral. So genital femoral, based on its names, it's composed of two. So genital and also the femoral. So for the genital, basically, what it does is actually it also innervates for the genital, the cremaster muscles, cremaster, the scrotal, the mons pubis, and also the labia majora. So basically it gives some innervations to here. Sorry, this is the genital femoral. So it also gives some innervations to the mons pubis and also the labia majora. So let's sketch here. So the ilioinguinal basically it's gives innervations to this part. It's pink in color. Since it gives an innervations, there's no motor, there's nothing that can move there. So it's mainly cause some when there is a compressions on this nerve, it cause some pain, numbness, tingling sensations over there. And then what we have here is the genital femoral. So in between the genital and also the femoral, we have the genital femoral nerves, and here we have the obturator. So let's put it in blue. So it's a genital femoral. So basically it innervates cremaster, scrotal, mons pubis, and labia majora. And after that, what we have, this is L1 and L2. So after that, we have the L2, L3, and L4. So L2, L3, L4 basically will give rise to the femoral nerves, which will divide anteriorly and posteriorly, anterior and posterior. So it runs in between the iliac and also the psoas muscles. So psoas and iliac muscles. And the posterior branch will stimulate or give branches to the saphenous nerves. That is for the posterior. So it gives for the posterior it gives rise to the saphenous, and then all the vastus which includes the vastus. We have three vastus. Vastus basically, what we call it, lateral, medial, and also the intermediate. Okay, that is for the VNS. That is for the posterior part, posterior branch of the femoral. And for the anterior, it's basically innervates this area. This is the femoral, the anterior femoral nerve. So it's innervate the medial part of the thigh. And what else do we have here? L2, L3, and L4. Another thing that we have here is the lateral. What color? Lateral, femoral cutaneous nerves. Since the name is cutaneous, so it only gives an innervation to the skin. So there is a question about the meralgia, paresthesia, basically the compressions of the fetal head at third trimester, causing compression to the nerves, the lateral femoral cutaneous nerves, which also arise from the lumbar plexus. So the lateral femoral cutaneous will cause the burning, tingling sensations over the lateral part of the thigh. So that is meralgia, paresthesia. So another thing that we have here is the obturator, also from L2, L3, and L4, but it's located medially. So we have the obturator. So let's color in L2, L3, L4. So this is the obturator. What it does is, I always like, just imagine, because obturator will goes into the obturator foramen, right? So it will goes in here. So it gives innervations to Gapodia, gracilis, adductor, pectineus, and obturator, externus. And adductor, it includes the three adductor: longus, which is long, brevis, which is short, and also the magna. Adductor magnum. Okay, so basically what it does for this muscles is that it will cause an adduction. So basically, if you have a patient here, so the obturator will helps in the adductions into these positions. So adductions toward the central, adduction, abduction outside. So adduction is the obturator. That's very important, especially in case of the nerve compressions or nerve injury. As you know, it's always the one of the risk factor during the PLND. Okay, another question that they're gonna ask usually is about the anatomical landmark for this nerves. So as you can see here, all the branches this is psoas muscles, will go laterally from the psoas muscles, except for the obturator nerves. Obturator will go medially, so it's in the center, in the medially. And another one is the genital femoral. So the genital femoral, basically it will pierce through the psoas muscles and goes anteriorly. So if you imagine this is the psoas muscles, and this is the sacrum, and the lumbar and the sacrum. So the nerves basically pierce. This is obturator. Here is the genital femoral, and laterally is the rest, which is the ilioinguinal, iliohypogastric, and then the femoral. Okay, and we have the lateral femoral cutaneous. That is the question that they ask about the position, the anatomical landmark of the nerves. So that is for this part. Another thing that I forgot to mention is about the favorite question as well, about the common perineal. Common perineal. The common perineal basically causes a dorsiflex of the foot. So in case of the injury to this common perineal nerves, usually the patient will have the difficulty to dorsiflex, so causing a foot drop. Especially in the case of gynae onco case, or a patient where when we put in the lithotomy positions, so they're going to compress here due to the yellow fin or lithotomy, so it causes the injury and foot drop. So just some recap. Obturator nerves, it helps in the adductions of the hip, and then genital femoral, basically just here, so there is no much movement in female. And then we have the lateral femoral cutaneous. It gives myalgia, paresthesia, which is the tingling and burning sensations here, and the common perineal nerves, where it causes foot drop. And the femoral, since it actually gives rise to these muscles, the innervations, and the anterior parts of the femoral will give also stimulations to pectineus, quadratus femori, and also the sartorius. Looking at these muscles, you will understand that these nerves basically will cause a extensions of the knee and also the hip. So if the patient had injury to the femoral nerves, so there will be no knee jerk, absence in the knee jerk because of the injury. So this picture is not yet complete. We have the hypogastric here, we have the ilioinguinal labia, and we have the genital femoral, which innervates the mole pubis and also the labia majora. But another things that we should not forget is about our beloved pudendal, favorite pudendal ever, where we have this pudendal which gives the innervations to dorsal clitoris, the perineal, which includes the urethra, the external sphincter of the urethra, and also the urethral vagina. And also we have the inferior rectal, which gives innervations to the external anal sphincter. So that is for the lumbar. So let's talk about the sacral plexus.